One is the liver, and the second is the pancreas. As we can see here, we have a liver photograph. This liver is abnormal. Why? Because the cut sectioning shows yellow, pale appearance, and this is not the normal appearance of the liver. This appearance also can be seen also in the capsule. So this, we call it fatty changes of the liver. This is a more serious or more advanced fatty changes of the liver. Why? Because it's a homogeneous yellow, pale appearance of the liver. In this case, if it is extremely yellow, we can say it's because of the nutritional etiology. So the patient will be having poor protein, and when the acid metabolism of the liver is deranged. What is fatty liver? When there is a lipid vacuole inside the hepatocyte. Why? Because there is an abnormality of the lipoprotein transported, or there is a damage into the hepatocyte of the liver, or there is a mitochondrial or microsomal functioning, malfunctioning of the hepatocyte. These all will cause lipid vacuole inside the hepatocyte. This condition, we call it fatty changes, or microvesicle of the lipid vacuoles. This is more serious changes. Again, we can see the lipid protein inside the hepatocyte. One of the most common cause of this condition is alcoholism. If the patient have not any history of alcohol, we call it non-alcoholic fatty liver changes. These changes also can be seen in other conditions like diabetes, obesity, metabolic syndrome, and some gastrointestinal malabsorption. This is a trichrome staining that is staining the collagen. So this is indicate fibrosis of the stroma. It's like blue in color. Why fibrosis? Because fatty liver can lead to fibrosis, and fibrosis will lead to cirrhosis by the many years of fibrosis. This is an ongoing liver damage. Why? Because the surface is not smooth as the normal liver. It is a micro. This is a micronodules or a macro. How to differentiate? If it is more than 3 millimeter, we call it a macronodular. If it is less than 3 millimeter, we call it a micronodular cirrhosis. This condition will develop over years. Again, here we have another example of macronodular cirrhosis of the liver. Most common cause of cirrhosis is viral hepatitis B and C. This is also, again, macronodular cirrhosis and fibrosis is seen that is disturbing the architecture of the liver lobules. As a consequence of this condition, we can have splenomegaly, ascites, and esophageal varices. All these in one term called portal hypertension. So portal hypertension is a consequence of liver cirrhosis that will lead to, again, splenomegaly, ascites, and esophageal varices. This is a cirrhosis, again, of the liver. As we said, the first common cause of it is alcoholism. This is a micronodular cirrhosis. Why? The size of the nodule is less than 3 millimeter. Again, the same etiology is alcoholism. Or micro or macro. The most common cause is alcoholism. If there is no alcoholism history, we call it non-fatty liver changes or non-fatty liver, non-alcoholic fatty liver disease. But we can see it in other conditions, not only the alcohol. This is a micronodular cirrhosis of the liver with fatty changes. Why fatty? Because we said the yellow pale appearance is due to the fat. So yellow, small nodules are seen on the surface of the liver. Here we can see Wilms disease also can cause primary biliary cirrhosis and hemochromatosis. Again, if there is any fibrosis, the liver will try to regenerate itself by regenerative nodules. How we can see it under the microscope, the regenerative nodules will be surrounded by fibrous connective tissue. Sometimes in the fibrous connective tissue we can see scattered inflammatory cells. This appearance called regenerative nodules. This is because the liver trying to adapt or trying to make over of the hepatocyte that was injured. This is again regenerative nodule surrounded by a connective tissue, and there are scattered inflammatory cells seen. This is a high magnification. We can see this amorphic red hyaline material seen inside the hepatocyte. This is not case of alcoholic hyaline because this is the most common cause of alcoholic. So this can be inside the hepatocyte, here and here. Biliary hyaline also seen here, but there is also neutrophil scattered seen. If there is any neutrophil seen, so this condition is called acute hepatitis. Alcoholic, why? Because it is having steatosis or vacuoles, lipid vacuole inside. So acute hepatitis, acute alcoholic hepatitis. We said that consequences of cirrhosis is portal hypertension. One of the many results of portal hypertension is splenomegaly, capitis metosa, esophageal varices, and ascites. Capitis metosa is the dilation of the venous around the abdomen. Why? Because the body try to regenerate or try to having more blood flow into the liver. So it takes the arterioles or the venules and it will be dilated with the blood. So this is around the abdomen. It's called the capitis metosa. As we said, it's called also in the esophagus, esophageal varices. Most likely seen in the lower third of the esophagus. These are easily eroded, so it will lead to massive gastrointestinal hemorrhage. This is the spleen, but this is not the normal one. It is enlarged. The normal spleen weighing 150 or 300 grams. But this one is much higher in weight than the normal one, and we can see here the tan surface. Here also the pale tan surface. This is called sugar acing or hyaline splenitis. This splenomegaly can be the result of cirrhosis and portal hypertension. This one, a result of portal hypertension. As we said, that is create a shunt or collateral venules. Wait. This only. Okay. Another one, the hepatocyte. This one. In this picture, we can see a yellowish green accumulation pigment. This pigment is the bile. If there is a bile accumulation inside the liver, it's called a cholestasis. Bile accumulation could be due to post or extrahepatic obstruction. This bile accumulation will lead to hepatocyte injury. Again, small brown yellow plug or bile seen in the canaliculi. This is clinically we'll see in the patient as a jaundice or icterus, most likely seen in the sclera. If it is due to extrahepatic obstruction, the bile will be conjugated, not like the hemolytic anemia or hemolysis. It is the unconjugated or the indirect bilirubin. In this picture, we can see a benign hemangioma or collection of blood just beneath the capsule of the liver. Sometimes we can see it multiple, so they are mistaking it by carcinoma, but actually it's a hemangioma or collection of blood. Here we can see below the capsule there is a well-circumscribed neoplasm arising within the liver. Why we say within the liver? Because it's the same architecture or same color of the liver. So if it is well circumscribed and there is no other satellite nodules, we can conclude that this will be a benign tumor, which is here the hepatic adenoma. Again, we can see beneath the capsule there is a well circumscribed nodule. The cut surface showed a yellow surface. So this one will be again hepatic adenoma. Hepatic adenoma most likely under the capsule. This is a closer picture of the same one. This is the normal tissue, canaliculi and the plates, normally 2 to 3 cells, and this is the bottom tract. This one, we can see the hepatocyte. The plate was more than 2 to 3 cells. So this is architecturally abnormal or disorganized of the architecture. Here we can see, again, well circumscribed, but the nodule is very large from the previous one, and the cut surface is turned, but there is here area, it shows a necrosis. So in this case, we can conclude that this will be carcinoma. Why again carcinoma? We can see here also satellite nodules. So we suspect carcinoma in this case. This is a closer view of the previous one. Satellite nodules, some necrosis, and this one greenish in color. Again, hepatocellular carcinoma. Why? Because ill-defined surface, and there is a multiple or satellite nodule seen. In this case, sometimes the patient will be having elevated serum alpha-fetoprotein, which is not seen in adults, it's only in children. This mass could obstruct the biliary tract, so there will be extrahepatic biliary obstruction. So there will be accumulation of the bile inside the hepatocyte. ليش؟ إذا في سؤال عادي. So in this case, there will be extrahepatic obstruction. So that will lead the bile to be accumulation in the hepatocyte, and also alkaline phosphatase to be elevated. Why this is important? Because if we have cholangiocarcinoma, this feature will not be there. Accumulation of the bile will not be there in cholangiocarcinoma. This is a hepatocellular carcinoma.